I'm delighted to have Richard Totaro online. Richard is an intensive care specialist at RPA Hospital. RPA is a cardiac centre essentially in Sydney, and he is going to present his case now. Thank you, Richard.
Good morning. Thanks, Brian. Can I just confirm you can hear me?
We can hear you loud and clear.
Excellent. And the slides on the screen?
Yep.
Great. Okay. Hi, everyone. Thanks a lot for the invitation to present another case. Now, after Natalie's excellent talk just prior to this one, there is a little bit of duplication, but we'll see how we go. So I've got no financial disclosures. Our first case really lines up how ECPR, even in what may look like the most simple case, nothing is simple in these patients. So Prince Alfred is set up very similarly to Westmead. We've got a service which provides a Monday to Friday extended ECPR service. We run 8 to 6. We can guarantee that service. And that's because it's such a highly technical workforce-dependent procedure. It needs really specialised teams, and we can provide the service in those hours. So it's 3 o'clock on a Sunday afternoon, and our patient develops crushing left-sided chest pain at home. The first entry we have in the notes of Prince Alfred is the triage note, which was that there was a bat call, patient brought in from home, moaning, rolling around in the bed with crushing chest pain, and the LifeNet ECG showed a STEMI. And as he arrived in the hospital and was put into a trolley in the ED, and here's the ED summary, which is a really good record of what happened. As the doctor was inserting a cannula, the patient went into conscious VT and then arrested. The arrest alarm was set off, and I'm just going to run through this. So the first rhythm check was VT. There was no end-tidal CO2 recorded, and they started CPR. With the CPR ongoing, the patient was moaning, but they continued their chest compressions. Next rhythm check a few minutes later still showed a shockable rhythm. 200 joules was applied again, and 1 milligram of adrenaline was given. Manual CPR was ongoing. About a minute after that, the Lucas had been brought out of its case and was being applied. The patient now actually had some return of spontaneous circulation. The CPR chest compressions were stopped, and because of the return of spontaneous circulation, the cath lab was activated, and those obs were shown. So the patient was breathing spontaneously with the bag mask device. The SATs were a little bit low. He was tachycardic and had a reasonable blood pressure after the adrenaline, but was now unconscious. A couple of minutes after that, his rhythm deteriorated again to VT. He was shocked again. He was given some amiodarone with the bag mask valve on. The end-tidal was now recordable. The ECG was being done. The Lucas wasn't running at that point. And then a couple of minutes later, the eCPR call was put out. Come back to that in a moment. Continued to do the rhythm checks, and now the rhythm had deteriorated to a non-shockable rhythm, so he wasn't shocked. There was no recordable end-tidal CO2, but because of some signs of life, the doctor gave it a little bit of ketamine for sedation and comfort. Another rhythm check, again a shockable rhythm. He was shocked this time. CPR was continued because there was no return of spontaneous circulation. So what does it mean at Prince Alfred when an eCPR call is put out? Well, it means that the patient has fulfilled some of these all of these criteria in the green boxes. Is it refractory VT-VF or pulseless electrical activity? Is the patient's cause of cardiac arrest reversible? Was it witnessed? Was BLS commenced? Had they arrived within 60 minutes of the arrest in the ED? And did they have a measurable end-tidal CO2? The age criteria that we have here, age criteria related to the RESET trial. For eCPR, we don't have age criteria strictly. So because this patient fulfilled all those criteria, 2 things happened. First of all was a 2222 call, which sets out an ECMO CPR to ED page, and then a phone call directly to this one number, which is the ECMO intensivist mobile number that is carried all the time. The ECMO CPR call goes to these people. the cardiology registrar, critical care resource nurse, ICU reg, ICU after hours num, the cardiac thoracic reg, and the cardiac anaesthetist. And those people then pull together extra gear. However, this was 3 o'clock now 4 o'clock on a Sunday afternoon. But because the ECMO intensivist happened to live very close to the hospital, and there was another intensivist around who could drive the echocardiography probe, it was decided to go ahead. And this is what we aim to get. We aim to get a team together which can change 4 tyres in 1.8 seconds. And very similarly to what Natalie showed us earlier, what we try to do is get, before the patient arrives, get everybody in place. And this is our placement around the bed space with 2 cannulators and assistant medical and nursing team leaders, the monitors pushed aside, the airway doctor and nurse at the head of the bed, the cardiac anaesthetist with the toe probe and so on. We've got like Natalie said, a pre-prime machine in the ED. We've got a trolley with all the gear ready and raring to go. And this is what our bed space looks like once all the equipment has been pulled together. This is obviously minus the large crowd that somehow always appears during these CPR cases. When the patient arrives, these are the steps that the ED go through, and this is all credit to Matt Oliver and his team in the ED who've put together these various phases of the process. During the cannulation phase, like Natalie said, there's no defib, there's no adrenaline given, the Lucas is continued all the time, except for a few interruptions, which we'll talk about during the cannulation phase. Once the patient's on, we continue Lucas for a period of time to empty the heart, and then we'll try a few more defibrillations to get the heart going again. And then we move on to placing some monitoring lines and some drug lines. And then after the ECMO, there is a whole series of things that go through. And in particular, this one, which we'll talk about, which is if there's a STEMI diagnosed on the ECG, we go straight to the cath lab. And if there isn't, then we decide what the next best step is. Do we try to diagnose a PE? Do we go to the cath lab anyway, despite the absence of ECG changes and so on? These are clinical decisions made on the fly at the time. So once the CPR phase for this patient had started, rhythm checks were stopped, the drapes went on, CPR continued. Because this had all happened very quickly and in the ED, once the drapes went on, then the team moved to intubate the patient and to insert the toe probe while the cannulator got some sheaths in place, and then we got through to the cannulation step. And I'll just skip through those steps for a moment. And this is the cannulation process, and I'm just going to summarise what happens here, and I'll show you what it all means in a sec. So the first step is we put a couple of little cannulas or relatively little cannulas into an artery and a vein, and then we upgrade those to bigger cannulas, and then we put the patient on. So what are the little cannulas? These are the sheaths that we put in. They're colour-coded. This one here goes into the artery. This one here goes into the vein. It's about 4 and 6 French respectively. And we use those sheaths as our access. And we get those sheaths in place using the ultrasound. And this is really vital to the whole process, is seeing the vessel and watching the needle. And you can see the tip of the needle going into the vessel there. And then once that tip of the needle is in, we get some wires in and push these sheaths into those vessels. And we use those as guides for the next step. And the next step is to get these very big cannulas in. And these cannulas are anywhere between 17 French and 25 French. So very big cannulas that go into the vessels. And it's all done on a moving target. So this is a little bit after the phase. You can see here the wire being looped up. That wire, first of all, is pushed up into the right atrium, and then the venous line that you saw bleeding onto the bed there is put in place. And then that wire is passed up into the upper femoral artery into the aorta, and you can see the arterial cannula being connected there to the red tubing. And then once everything is connected up, Being very careful to remove all the air from the circuit, because the last thing we want to do is push a little air bubble into the arterial system and give the patient a stroke. Once it's connected up, then the blood flows through the machine, and then the ECMO pump pushes nice red oxygenated blood at high pressure back into the patient. Now the ECMO pump is taking over the circulation, and we can go and continue to think about how we sort out what happens next to this patient. This wasn't the patient that we're talking about today. So within an hour of having his arrest, the patient was being transferred up to the angiography suite. At angio, we saw this picture, and what you can see here is a left main coronary artery which is completely occluded at the bifurcation to the LAD. Very quickly, our cardiologist had a wire across that occlusion and had got a little bit of blood flow coming down it. And within about 10, 15 minutes, the angiographer had now got 2 or 3 stents through that occlusion, and the patient had a nice, well-perfused left ventricle. And you can see the difference between that one and this one, just how amazing these interventional cardiologists can be at getting blood flow back. Now, while this was happening, the social workers and the ED team had got the patient into the patient's family into a side room, and were getting a little bit of extra information. And we got a bit of a surprise when we got that extra information, in that the patient about 30 years ago had had bilateral nephrectomies, which was a bit of a surprise to us. And when I pulled aside the drapes and looked underneath it, sure enough, the patient had 2 great big scars where his kidneys had been taken out. But we couldn't find a AV fistula where he was being dialyzed. And in fact, he'd had a renal graft from one of his siblings and had a renal transplant in place, which was a bit of a surprise to us, and also made me break out in a cold sweat, because renal grafts are usually put into the right or left iliac fossa, and they're plumbed onto this iliac artery here that you can see. And sorry, let me draw that for you. So here's the graft, and here's the artery going into the iliac fossa. And the thing that caused me quite a lot of concern about this is that when we put a cannula in, we put a cannula right up the iliac artery, and the chances are that that big cannula that we put in was completely obstructing the blood flow to that renal graft. Nothing is simple in ECPR. I looked under the drapes, and sure enough, there was no urine in the urine bag. And so I started to think about what the heck we're going to do. And I don't think this is going to be an interactive session, but I was going to ask the audience, what do we do at this point? And what did I do? I called some friends. We had a chat between the ICU ECMO team, the cardiologist, the cardiothoracic surgeons, the cardiac anaesthetists, the renal physicians, and the vascular and transplant surgeons, and decided what we were going to do. And the decision we made was that we were going to see if we could get this guy straight off ECMO at that point, because he'd had quite impressive hemodynamic improvement to the reopening of his left main coronary artery. So we went straight from the cath lab down to the hybrid lab and the operating theatres with our vascular surgeon, who is also a renal transplant surgeon. Cardiac anaesthetist put in a pulmonary artery catheter, did a toe, put in a central line, got some measurements. And luckily for the patient, at this point, we're about 2 hours from his arrest. He was on minimal vasopressors. He had good LV function, an LVOT measured at VTI of about 13 centimetres, and we'd like to have over 12 when we're weaning patients. His right ventricle was contracting well on the toe. His ejection fraction on the left side was about 35 to 40%. And with just a trickle of dobutamine, just a small dose of an inotrope, his LVOT VTI came up to about 16. So we're pretty confident that his cardiac output was actually quite good. And his pulmonary artery occlusion pressure, his wedge, was quite good too at 14. So we thought his LV was not failing, and that he probably would come off quite well. And so at that point, the vascular surgeon decannulated the cannula from the right leg. You can see here you can see here what I mean about the cannula pretty much occluding the artery there. And here's the angiogram that was taken after the decannulation. And you can see that there's a kidney sitting here, which at the moment is not getting as much blood as we would hope. But with the cannula out, there was more blood going into the kidney than was going in there before. So what happened to this fella? Let's skip forward to day 4. He's now extubated. He's sitting out of bed. The nursing entries say that he's looking a little bit stunned, but he's really doing impressively well. Unfortunately, at about 4 o'clock in the afternoon on day 4, he gets a new onset of speech loss, some right arm weakness, and some confusion. So he's very quickly taken up he gets an ECR call, which is a stroke call. He gets very quickly taken up to the CT scanner, and they demonstrated a left middle cerebral artery stroke, a very small one that was quite peripheral, that was too small to be able to be managed invasively. So he didn't get thrombolysis, and he didn't get any invasive neuroradiological interventions. His MRI, about 7 days later, shows just this small stroke here. So it's really relatively small one. His kidneys did have a period of acute kidney failure with a peak creatinine about 480, urea of 30, but he was never dialyzed, and now his creatinine's almost back down to his baseline, about 115. He was continued on dual antiplatelet therapy, a TOE on day 12, which was done after the stroke, showed no intracardiac clot, showed quite a good LV with some mild impairment and a small regional wall motion abnormality and a normal RV, and he went home on day 13, which all sounds pretty good, but of course nothing is simple. And when he was seen as an outpatient by our post-cardiac arrest team, which was the speech pathologists and the occupational therapists from the stroke service, they actually flagged that he had not a whole lot, but he had some neurological insults with some visuospatial problems, some constructional skills, some functional skill problems, slow calculation. But on the other hand, he was able to wander down to the hospital cafe on his own. He was able to walk around the ward without any difficulties. And the speech pathologist was relatively optimistic about what would happen to him. So we're not quite a Formula One team. We didn't get the cannulas in 1.8 seconds. But this fella, from his first call to the ECMO CPR team to flow on about 34 minutes later on a Sunday afternoon with a very good neurological outcome, I think shows some of the good sides of what can happen with ECMO CPR. And that's it.
Thank you very much, Richard. I think it's really good that Richard has presented a case that highlights some of the issues that occur when we're trying to do something in a very expedited manner. And sometimes we don't pick up the unexpected. One of the things we are introducing for paramedics when they do the handover in the eCPR sites is a rapid checklist, which will include the medical history. Now, the medical history isn't front and center. So while the ECMO team are getting ready, getting the wires in, the sheets in, then there's almost like a second phase where the team leader is hearing the medical history, and that's potentially where something like this may potentially have been picked up. And I suppose, Richard, in that instance, if you knew, you still would have proceeded to ECMO, but would have gone left-sided, presumably. Is that right?
Absolutely. It would have been a simple swap from right to left for the artery, and we would have been able to avoid late evening call out on a Sunday to the hybrid lab. You would have stayed on till the next day and had a more elective decannulation.
Excellent. And the second question is around, or question really rather than comment, is around other diagnoses. So there's a big discussion point around the PEA group, and Dimitri will touch on that later. Obviously, the VF group are by and large going to be coronary occlusions. So once they're on ECMO, we know what we're looking for, which is to go to the cath lab. Is there a role for the TOE operator and the cardiac anaesthetist who's doing the TOE to verbally exclude other unexpected diagnoses such as massive PE, pericardial tamponade, aortic dissection.
Yeah, and that happens in real time. Once the Totaro goes in, with the echocardiographer will have a quick look around before focusing on the bicaval view and the descending aorta to look for the wires.
Excellent. Any questions online, Nat? No. It's quite late, I think, where some people are watching this. Anyone in the audience? We've all been bitten by cases where we thought, we thought we were kind of going along the right track and then found an issue. I think it's really good the way they adapted very, very quickly and kind of rallied and switched to a different focus, and patients still had a really good outcome.